Good morning, everyone. Thank you for getting out of bed so early. Thanks for the thumbs up if they were indeed out there. I didn't see them. I did. Yeah, thank you. All right. I really appreciate Rajam's invitation to be here. I appreciate that kind introduction. I appreciate you guys showing up, especially first thing in the morning after a networking event that had alcohol flowing. So I appreciate the commitment, as it were. I have three things I want to try and do today in the time allotted to me. The first is just to talk generally about my understanding of what clinical psychologists do in the treatment of chronic pain, or perhaps, if I'm being more honest, what I think they ought to do in the treatment of chronic pain. I'm going to talk about this treatment approach that's called acceptance and commitment therapy, or ACT for short. I hope to give you an overview of what ACT is, what it does, the outcomes that it tries to achieve. I'm going to spend a particularly significant amount of time in my talk speaking about things like willingness to experience pain and commitment to engagement in activities that matter. These are my understanding of what's at the core of ACT and are the core behaviors that we're trying to shift in those that we treat. And then along the way, we'll look at the data so that you've got some idea of what the evidence out there looks like. I'd like to start with what is perhaps a radical idea, and that idea is this. For a lot of people out there who have chronic pain, pain intensity is likely to be a fundamentally untreatable symptom. And when I say fundamentally untreatable, I mean I'm not sure how many patients I've seen in my career, but I'm pretty sure I've never seen one and successfully treated them and achieved complete elimination of pain. I'm pretty sure the data out there suggests that complete pain elimination is incredibly rare in individuals who've had pain for longer than 3 or 6 months, oftentimes longer than 3 or 6 years, right? And I'm not necessarily here to debate this pain intensity question today. I will if you want, but I just ask you to consider what we know about chronic pain. We know that chronic pain, or chronically episodic pain, is incredibly common. 1 out of every 3 to 5 adults in developed countries seem to have it. We know that chronic pain is incredibly persistent and that it seems to remit in only a minority of cases. So we've got a number of large-scale, well-designed epidemiological studies that tell us pain is common. We've got a number of large-scale, well-designed longitudinal studies which suggest that pain is persistent. The longest follow-up study I'm aware of is this one of Gerhardt Anderson, which was a 12-year follow-up study. At 12 years following a baseline assessment which indicated the presence of chronic pain, 86% of individuals still had chronic pain. And that number is not unusual. The shorter term study up there, Elliott et al., this was a UK study, which is a 2-year follow-up. If my memory serves, like 80 to 82% of individuals continue to have pain 2 years later. And we assume in the interim between these assessment points that some kind of intervention has happened, right, of some sort. They've done something, and yet pain has persisted. And then finally, we know that pain in those who have chronic pain is really hard to reduce in a way that is clean, meaning that doesn't contribute to a number of other problematic side effects, or in a way that's persistent. I see people snapping photos too. I'm more than happy to send slides. You can keep snapping photos, I don't mind at all, but I'm happy to send you slides too. So just let me know. My email's at the end of this. Or if you take a picture of me, get my good side with the slides in the background. So anyway, back on track. We know it's hard to reduce pain, and we have a vast and sophisticated clinical armamentarium at our disposal that just doesn't seem to work as well as we'd like it to. Just a snippet of some of the data out there that I'm sure you're all aware of. We know that opioids. I lived in the UK for about 7 years, and I returned to this country about 3 years ago, and I was absolutely floored by the exponential increase in opioids and the exponential increase in opioid-related problems that had occurred in this country of ours. At this point in time, there's no supportive evidence that opioids lead to pain reduction in individuals who've been taking them for longer than 4 months. When's the last time you saw a person who had pain had been taking opioids for less than 4 months? Never. We know that continued pain and disability are the absolute norm following surgery. We know that the story is much the same for implantable devices. There's a great series of studies. I talked about this 2 days ago, published by Kemmler et al., the first one in the New England Journal of Medicine in 2000, which investigated the efficacy of spinal cord stimulator implantation. Everybody know what a spinal cord stimulator is in this room? I assume that's true. Battery pack put into your abdominal cavity, electrodes over your spinal cord, pass faint electrical current. Spinal cord stimulation plus PT versus PT alone. What they found in this trial at 1 year and 2 years was that spinal cord stimulator implantation was indeed associated with less pain than PT alone, but that there were no differences in functioning or quality of life. So think about that for just a second. No differences in functioning or quality of life. That reduced pain was then absent at 3, 4, and 5-year follow-up studies, and it's great that they published these things. So fairly transient 2-year reduction in pain, no change in functioning at any time point. And finally, and my purpose here, bless you, is not to make fun of any interventions or anything of that sort. My point here is just to indicate how incredibly hard it is to get clean and reliable pain reduction. Epidural steroid injections. In 2005, the American Academy of Neurology commissioned a group to do a systematic review and draft a set of clinical guidelines with regard to epidural steroid injections and their evidence for use in low back pain and neck pain. What they found was that for lumbar pain, epidural steroid injections were probably not effective for long-term pain reduction, improved functioning, or decreasing rates of surgery, although they did allow for some short-term pain reduction, which could be ascribed to the local anesthetic that individuals were given as this needle was being put into their spine. Probably not effective was the lowest grading of evidence, the second lowest, grading of evidence. The only thing below that was no evidence at all. For cervical pain, they said there's no evidence at all. And it is findings like this that have led some other healthcare systems to say things like no more epidural steroid injections for those who have chronic pain. In the UK, there's an institute called the National Institute for Clinical Excellence, or NICE, as they call themselves. And their job is to commission healthcare interventions. In 2007, 2008, NICE said no more epidural steroid injections for low back pain. Not because they were trying to be mean or trying to restrict services or trying to save money, but because they said these treatments are just not doing the thing that we want them to do. So I have a question. If pain is not the thing that we're trying to treat, what is it that we're trying to treat? And I have a few answers, perhaps. Like any individual who tries to be a good scientist, when I'm presented with a question I don't know the answer to, I go to Google and type in some stuff and kind of see what happens. So this is a search that I did a few years ago now when I was getting ready to speak to a group of individuals with chronic pain, and I wanted to try and find a way to present this message to them. This isn't really about pain, this is about life, in a way that didn't get me beat up. And so I searched 2 specific terms that I hear from time to time in my clinical practice. The first one here, I hope you can see it, is I just want my life back and chronic pain. That seems to come up with a degree of frequency when I see patients at assessment. And then the other one here is a term that I hear less. I just want this pain to go away, but I hear it with a degree of frequency as well, and chronic pain. Of course, in no ways is this a scientific survey. In no ways is this necessarily representative of what's going on out there, but the results of these 2 searches genuinely surprised me. For the first, about 1.4 million results for that very specific set of words put together in that very specific way. And I looked through some of them, by no means 1.4 million of them, and most of them said about the same thing, which is this pain is messing up my life, and I just want to get back to it. For this other one, I just want this pain to go away, about 4,000 results. Perhaps I didn't search the right statements, but that seems like a meaningful difference to me. 1.4 to 4,000. If someone was giving me money, I know which one I would select. And the very first one here was some guy saying, I just want this pain to go away enough so that I can get back to living. So Google has a clue out there in terms of what we might be wanting to treat when we're treating individuals who have chronic pain. Very quickly, for those of you who spent 4 hours with me 2 days ago, there are a couple of slides in here that are the same, and this is one of them. I'm sorry for that. If the punchline is the same and if the joke I make is the same, I'd appreciate some laughter, because you might know what's coming. Anyway, I used to do a small amount of legal consulting work, and I don't anymore. Those of you who have done this kind of work, you know the drill. You get a huge set of files, and you're supposed to go through it and read everything, and then say something clever at the end, right? So years ago, I was going through a file. I came across a handwritten letter that a patient had written to her provider, to her physician, trying to explain to him what the experience of pain was like for her. Maybe you've seen these letters before, or maybe you've gotten them yourself. And she said a few things that really struck me as important. So here's some of the things she said. She said, I'm trying to do more to take the load off of my husband and off of my daughter. She says, if there are no cares and I'm bad, I don't wash, I don't eat, I don't take care of these kind of very basic needs, these things that are quite low on Maslow's hierarchy of needs. She says, the pain's all right, but I got this funny stuff going on in my neck, and it's starting to make my arms and my legs feel weird, and that's starting to freak me out. She says, I can cope with the pain, but I'm also starting to fall, and that's dangerous. She says, the house is a mess, my husband is stressed and depressed, and my daughter stays away. And she concluded the letter by saying, I'm very positive and cheery. I'm not sure about the accuracy of that one, but that's not the point here, right? Given everything that's preceded it. But I'm worried it's not doing me any favors, as I think people don't understand how bad things are for me. And what struck me in this letter was the number of treatment targets that are here, the number of things she's saying, this is the stuff I want to treat or to have treated. And not a single one of them is pain. And as I said 2 days ago, you just have to trust me, the rest of the letter was not like pain, 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 pain. It wasn't. It was talking about the ways that pain had fundamentally impacted her life in the negative. This fundamental impact in the negative is something that Fordyce 40 years ago called suffering. And Fordyce said pain and suffering are different. Suffering is the impact of pain on the lives of people who are experiencing it. Here's a model of pain and suffering, and it's not a very clever model. The model is this: pain leads to suffering. Our patients know this model. If you want to test this model later, I'd encourage you, if you see a small toddler walking along the street or something like that, go trip them and see if pain does indeed induce suffering of some sort. And the point here is our patients get this. They get it. Pain's screwing up my life, and it's leading to suffering. If I can just get the pain down, then I ought to be able to get the suffering down. And that model is absolutely accurate if we can get pain down. But I've just spent 10 minutes talking about how hard it is to get pain down. Our patients know it. This is some data we published a long time ago. It was a questionnaire development study where we were trying to assess degree of pain willingness or pain unwillingness in people. One particular item, it's important to keep fighting this pain, struck us as odd in many ways, because the overwhelming majority of patients, 92%, said always true or almost always true, the two highest levels of endorsement. It is important for us to keep fighting this good fight. From a psychometric or questionnaire development perspective, this is a bad item because there's no differentiation between people who are filling it out. Everybody's saying it's important to keep fighting this fight. And the only problem with fighting this fight or struggling for pain control is that it seems to be a very reliable predictor of trouble. The more time people spend in their daily life struggling for pain control, the more disrupted their life seems to be. It's another questionnaire. It's called the Brief Pain Coping Inventory 2, because we thought it was clever to name the second one too. And it assesses a number of ways of responding to pain. It asks people, out of the past 7 days, how many days have you engaged in these kinds of behaviors in response to pain? And it's a mix of kind of positive behaviors or things that we would think are good, a mix of negative behaviors or aversive behaviors. And one of them is, how many days out of the past 7 have you struggled for pain control? And at an item level of analysis, that single item is the best predictor of functioning that we found across all of these different ways of functioning, such that if individuals were spending most days out of the week struggling for pain control, they reliably have worse pain, poorer activity, greater levels of disability, greater depression and distress, more pain-related fear and avoidance, more pain-related healthcare utilization. And we've investigated this across time and situation, so it has longitudinal value. We've assessed it in adolescents, adults, and older adults. We've assessed it in primary care and tertiary care, maybe in a few other ways we've assessed it that I can't remember right now. In other words, it seems to be one of these findings that is reliable. The more time people spend struggling for pain control, the worse off they tend to be. And so it's not that this model is wrong, it's right. It's that this model might not quite be adequate when it comes to the treatment of chronic pain. And a more adequate model might look something like this. I'll walk you through this in a moment. If you've spent time with psychologists, you'll know that models that only have one arrow make us incredibly nervous. And so I don't know if this is a better model or not, but gosh, it's got more arrows, so that makes me feel a little bit better. Anyway, you'll see that we got pain and we got suffering, right? This is hard to do. We got pain, we got suffering. But down in that lower circle, we have responses to suffering. And from the perspective of ACT and certainly other treatments, we can do something about responses to pain and suffering if we can't do anything about pain. And so here we've got suffering, when it is accompanied by struggling for pain control, contributes to failure. Because we know that struggling for pain control is associated with poor outcomes. The data suggests this is so. We know that as people fail to gain pain control, their behavior becomes very restricted, such that more and more of their time is spent in pain escape or pain avoidance efforts. And that comes at a cost, and that cost can be summarized perhaps as losses in freedom and opportunity. People say things like, my husband is stressed and depressed, my daughter stays away, my coworkers don't call anymore, I don't show up. When my friends call, I tell them no, and then they stop calling me. In extreme cases, I don't get out of bed. In super extreme cases, I never leave my room. Have you guys seen this stuff? This happens, right? This happens. And that leads to both an increase in pain and an increase in suffering. And so maybe there are some things in this model we can do something about. We might be able to decrease struggling with pain, and we might be able to do that, just as a quick example, by asking people about things that are important and asking them if there's value here in a maintenance of a life direction. And I'll give you a definition of that in just a second. But the thing with maintaining a life direction is that it is successful, or let me say that in a different way, the success is in the maintenance. So I have a daughter, she's 10, she's a very important thing in my life, very important person, I guess she's not really a thing, is she? But I am not always the kind of parent I want to be. When she was younger, and I gave this example, I would say like 3 a.m. in the morning when she's puking all over the place, not always displaying the parental skill I would like to display. Parents, you know what I'm talking about. Now that she's 10, there are different situations where I'm unable to display parental behavior in a way that I would like to. It's pre-adolescent thing is showing up. So there are times in my life where perhaps I'm not exactly as good a parent, excuse me, as I would like to be. But the maintenance is the important part. The return to the value of that area and trying to keep that importance in my life as a guiding principle. Does that make sense? All right, I'll take silence as yes. And with success ought to come increases in freedom and opportunity, or a broadening out of a behavioral repertoire, and that ought to lead to a reduction in suffering. This is one way of thinking about the model of ACT, and I'll show you some data that suggests that this model seems to work reasonably well in those who have chronic pain. One of the first studies we did was to try and alter struggle and chronic pain experimentally to see could we get people to struggle more with pain and struggle less, and would that have an impact on functioning in a standardized assessment test. So we took about 100 patients with low back pain. We asked them to engage in 7 physical tasks. These are the tasks on the physical impairment scale, for those of you who might be familiar with it. It's a test of flexion and extension, things like straight leg raise, and performance is measured via a goniometer, something I never knew that I'd use in a talk, a word I never knew I'd use in a talk, in order to try and classify range of movement and functioning. The nice thing about the physical impairment scale is that it has normative values, and so it allows you to not just look at range of motion or performance, it allows you to rate it in relation to normative values and then determine is this individual's performance in a level of disability or a level of kind of adequate functioning. So you can score it as a 0 or a 1, a 0 being not disabled, a 1 being disabled, and then you can get a continuous measure of disability from 0 to 7, which gives you an indication of how disabled folks are. We asked them to do that with a physical therapist when they came into our clinic. We then gave them a set of instructions, which in essence asked them to struggle more with pain or struggle less with pain. The struggle more instructions, this was an audio tape set of instructions that lasted 2.5 minutes. The struggle more set of instructions essentially said, we want you to do these tasks again, and we want you to get your pain under control. Research has said that people can do that. We were under no obligation to tell the truth. Research has said that people can do that, and when they're able to do that, their performance goes up. So we want you to get your pain under control and do better this second time through. In the struggle less group, we gave them a pain willingness or an acceptance kind of instruction where we said, what we want you to do is see if you can kind of let pain be. See if you can make your own decisions about how you're going to perform, and listen to what pain tells you, but you don't have to do what it says. And research has shown, which it definitely hadn't at that point in time, that if you're able to do this, that you can perform better. So struggle less and perform better. All right, so both individuals got this perform better set of instructions, but the method of performing better was different. So we assessed impairment on that 0 to 7 scale. We then gave them those audio taped instructions, and then we assessed impairment again. We had a third group, which we called a continued practice group, and we essentially just said, whatever you did the first time, do it again, and research has shown if you just keep doing what you're doing, your performance will increase. And I'm not going to talk about those data because those people's performance didn't change. Here's what happened in level of physical impairment here. The Struggle More group is in blue there. Their level of displayed disability got worse. They performed in a more disabled manner the second time through, a little bit. Scores went up a little bit. Struggle Less group, their level of displayed disability went down. I will highlight for you that this is a truncated scale here, so the physical impairment scale goes from 0 to 7, so it wasn't a huge effect. But we did get a pushing apart in performance based on these two different instructional sets. It was statistically significant, and perhaps most importantly, we assessed pain intensity. After every single physical task that they did, pain intensity was no different between the groups and had nothing to do with performance. And so from this, we thought we felt that perhaps we could clinically push struggle apart to see whether or not we could get better, more durable improvements in functioning. And while we're talking about struggle, it's worth talking about this acceptance word, because this is not just a matter of accepting it. Ilse Vian published a great study in Social Science and Medicine, 2005, something like that, where she asked people with pain, what do you think about acceptance? What do you think it means? And the most frequent definition at a patient level of what acceptance means was akin to roll over, give up all hope, play dead, you're done. Which is not really the treatment outcome we're looking for, right? At least as far as I know. And that's certainly not the message we want to send in treatment. The message we want to send is something like, with a bit more looseness and flexibility in responding to your pain, you might be able to free up your behavior to do the stuff you want. And so maybe there's some value here in understanding why we would be asking people to accept their pain or be more willing to do it. This is the second bit of data that I presented 2 days ago, but this is not a study of mine, and this is a study I wish I thought of. I love these data. This is an experimental pain study where they added an acceptance component onto a pain induction task that was similar to the one that I just described to you, the struggle more, struggle less. But they added they added a second component, a values component onto it, which was helping these undergraduates who were brought into the lab to define why in the world they might want to stay in contact with this painful stimulus. So as I just mentioned, these were undergrads brought into the lab. They were exposed to a cold pressor task, an ice water bath. If you keep your hand in an ice water bath for long enough, it starts to hurt. These experimenters measured 3 primary variables, which are fairly standard in these kinds of experimental pain induction tasks. They looked at pain threshold, which is the first one on your left there. When these individuals said they started to notice pain, they measured pain intensity, controlling for baseline pain intensity, and they measured what is perhaps the most important variable here, which is tolerance. How long did these individuals stay in contact with this aversive stimulus? At this point in time, it was fairly well established that if you did an acceptance kind of manipulation, let pain be, you decide when you're going to pull your hand out of the water, that you could increase tolerance time in comparison to a control condition. But no one had ever looked at this values thing in an experimental way. They also had a third group here, which you will have seen, which was the intention control group. This group was read to from the state constitution of Wisconsin for a half hour. And so whether or not that was an inert control condition or not, you can decide yourself. And here's what they found. In the values, let me talk about the values manipulation for a second. Here's how they explained it in the manuscript. They said when these undergrads came into the lab, we asked them about what's important to them. And that most of them said things like social relationships, friendships, or family relationships were important. And what we then tried to do was tie these important areas to the cold pressor task in such a way that we could make these relevant to one another. So they said, you're about to put your hand in this ice water bath, and as you have your hand in this ice water bath, think about these things that you said matter to you, and imagine that you remaining in contact with this painful stimulus would somehow allow you to engage in more values-based action. For example, if a family member or a friend was drowning in one of the millions of cold lakes they have around Wisconsin, imagine that you getting into that water and swimming out to help them, remaining in contact with this painful stimulus would allow you to render aid to the person who you care about. Cool, clever manipulation, but also fairly weak in that these undergraduates were in the laboratory. There was no lake, there was no drowning family member or friend, and we would assume they were operating under informed consent, right? They were told, take your hand out of the ice water bath whenever you want. So here's the results. At threshold, there were no differences. They all said that it started to hurt about 20 seconds in. For pain intensity, some differences started to emerge such that the acceptance plus values group said it hurt more than the control group, and there were no differences between that middle acceptance only group and the two other groups. But when they analyzed pain tolerance, some huge differences emerged, such that individuals in that acceptance condition, if we just look at these two for a moment, that's that fairly well-established finding at this point in time, the white line to the light blue line. If you do an acceptance manipulation, you get about a doubling on average of tolerance time. They added in this values condition and on average got another doubling of tolerance time. And this is an experimental study with undergraduates. Its relevance to chronic pain is not completely straightforward, but it does lead us to ask ourselves this question, which is, if people have a purpose, are they willing to remain in contact with aversives for longer in order to get at that purpose more efficiently or more significantly? So there's a focus in ACT on these things we call values. And values is it's not an important word by itself. There's a lot of other words that mean the same thing. But values, in essence, are the things that for us as humans form the answers to these kinds of questions. What makes you tick? What do you want this life of yours to stand for? Is your quality of life at this present moment adequate for your needs? And if it's not, what are the things you'd be doing that would make it rise above that level of adequacy? And generally, for most human beings, there are social relationships, there are caregiving relationships, significant intimate relationships. Here's some other potential values domains. By no means is this an inclusive list. But my guess is, as we look up there, most of us human beings, there's probably at least one or two things up here that make us tick. And my guess is also that as our patients look at this list, there's probably one or two things on there that make them tick too. Here's what we know about less struggling and more engagement in values-based action from the literature. We know that less struggling right now and more engagement in values-based activity right now in those who have chronic pain is associated with better physical and emotional functioning, all right? We know that if we look prospectively, people who are struggling less and engaging in more values-based action now are functioning better in the future emotionally and physically. And perhaps even more importantly, we know that if we design treatments which allow you to change these things, get people struggling less and doing more stuff that matters, that's associated with changes, improvements in emotional and physical functioning in the months and years that follow treatment. Longest follow-up study I'm aware of is one that we published in 2011 in Behavior Research and Therapy. It was a 3-year follow-up study. I'll show you those data in a couple minutes. 3 years following an interdisciplinary rehabilitation approach based on ACT, there was good maintenance of treatment gains, except for pain and except for physical disability, and we'll talk about those. So a potential model of treatment might look something like this. If we design our interventions to improve willingness to have the experience of pain, we add on to that more frequent, greater clarity and more frequent engagement in valued activity over the longer term, that ought to equal this. And I'll show you the data in treatment, but before we get there, I'm going to do it now. Perfect. These are our rehabilitation programs, and they're similar to rehabilitation programs that were more frequent in this fine country of ours. In the 80s and 90s, they are interdisciplinary, intensive, time-limited rehab programs. They consist of the services of a number of healthcare providers. Perhaps one difference in our treatment program is that treatment is explicitly about improving values-based action and willingness to have pain in the service of those values. They tend to be group-based. As I said, they tend to be fairly intensive. The least intensive program that we've offered is 2 days a week for a period of 4 weeks, with active treatment content of about 6.5 hours a day. That includes about 2 hours of physical activity or physical therapy, about an hour and a half of psychology, about an hour of OT or nursing or values clarity, a little bit of health education, a little bit of medical education, and a few other things thrown in there. And then we assess functioning at follow-up. And I'll say this. One of the reasons why I moved to the UK is because these programs were absolutely decimated in the 2000s in this country. Data that are out there of CARF-accredited interdisciplinary programs suggested something like 150 programs at their height in 95, something like that, and it's down to a low of something like 27. And I know you all know this. It's been a frustrating few decades. One of the reasons I came back to this country was Mexican food. But other than that, that's true, yep, was... because I thought I saw the pendulum swinging back. In some ways, the perverse problems that have been caused by opioid-related exponential increases in opioid use and added patient morbidity and mortality because of that has been to highlight the value of rehabilitative approaches. So I think the pendulum's swinging back the other way. In New Mexico, after 3.5 years of work, we are about to start an interdisciplinary program in April, which is huge, and I'm so excited about it. So I hope, we're at the end of one tunnel, and no doubt there are other tunnels ahead, but we might be coming to the end of one. Before I talk to you about treatment outcomes, I just want to talk to you a little bit about what we see happening in treatment. This is a diary we ask people to fill out each week of treatment. Generally, if we're doing treatment 2 days a week, we ask them to fill it out at the end of the first day or the beginning of the second day. Originally, we thought we would cleverly have them fill this out every day. And I love pain patients a lot. They're crusty. They tell you when you're asking them to do things that they're simply not willing to do. And they essentially told us to piss off with that idea. And so we decided we'd only do it every week then. So this is weekly data. We ask about things like pain intensity over the past week. What's your pain been like? We ask about distress, and I'm not going to talk about that immediately, but I will later. What's your distress level been like over the past week? We ask about struggle and unwillingness to experience pain. How willing were you to have pain or distress in the past week? How much effort did you put in struggling for pain control? And we ask about engagement in values-based activity and activities that bring meaning and vitality and quality to this business of living. And what we assume over the course of treatment is that pain intensity is going to do something over the 4 weeks of treatment. It's going to move around. Maybe it's going to come down. Maybe it's going to move around and end up at about the same spot. But what we assume is that this trajectory of change for pain intensity will have nothing to do with treatment outcome, because that's not what we're trying to do. But struggle and unwillingness we think are very important, the trajectories of change in these two things. We assume that as struggle goes down, that ought to free up behavior to engage in values-based activity. And this kind of X function or X trajectory, less struggle, more engagement in values-based activity, bless you, ought to be associated with treatment success. You with me here? This ought to be a prerequisite for treatment success. Bless you. Again, just let it out. Here's some patient data. Over our 4 weeks of treatment and then through 3-month follow-up. This was a woman in her late 40s who had fibromyalgia. She'd been struggling for years and years and years, a common problem, or a common story, right? Fibromyalgia had wrecked her life. This is what happened with pain intensity over the 4 weeks of treatment and at 3-month follow-up. It did some stuff, that's great. Here's what happened with struggle. And I don't mean to belittle this, by the way, not at all right? The point here is that we don't need to bring pain intensity down, hopefully, to get good treatment. Here's what happened with struggle, with pain and distress. It went up first 2 weeks of treatment. It spiked such that by the 3rd week of treatment, it was at its maximum. This is not uncommon for us to see as people who have been avoiding hard stuff in their life for a long time or whose lives have been falling apart for a long time, to come into treatment, come into contact with some of that stuff, and kind of freak out. No problem. If it had stayed up, we would have been worried, but it didn't do that. It dropped right down, such that by 3-month follow-up, it was at a 1. Engagement in values-based activity, again, we would hope would go up and stay up at 3-month follow-up, and that's exactly what this did. And so as we look at this pattern of change, we would say this pattern of change ought to be a pattern that indicates treatment success. When we looked at outcomes at 3-month follow-up, she showed a reliable improvement in disability on the sickness impact profile. Reliable improvement simply means the amount of change that she showed exceeded change that could be accounted for by measurement error alone. That's a big statistical mouthful. Essentially, we look at the SIP, try and figure out what its measurement error is, what the instability is in there. We identify a cut point, and if patients don't exceed that cut point in their change, we say they're not changed at all. All right, they're not reliably changed. They're not statistically reliably changed. So we saw reliable improvement in disability. We saw a decrease in the discrepancy between areas of importance in her life and success in those areas. So she started to become more successful in important areas, and discrepancy reduced from 70% to 25%. We also saw a reduction in pain-related medical visits in the 3 months preceding treatment and the 3 months after treatment, from 5 to 0. So it's hard, as all of you know in pain, to say unequivocally treatment success, right? We don't have a bacteria we are measuring that is now absent from the body. But I would say this is maybe as close as we can get to say it looks like there's some at least short-term success in treatment here. I'll show you 2 more patients' data. This is a gentleman in his early 50s who was a school teacher who had to retire from teaching because of some strange pain things that he had going on in his neck and in his head. First 4 weeks of treatment are here. You see kind of the same thing going on. Pain dropped down a little bit. That's fine. Struggle with pain and distress dropped down a bunch. Increases in engagement in values-based activity and quality of living. 3-month follow-up pain had come up a little bit. Struggle had dropped right down. Engagement in values-based activity had gone right up. Again, with this ought to be treatment success, as we look at outcomes here, reliable improvement in disability, a shrinking of that discrepancy, not quite as marked as the first person's data who I showed you, but still a shrinking. And then a reduction in pain-related medical visits from 15 to 2. So when we're talking to funders, these are the data we trot out. And of course, treatment doesn't always work. This is a younger individual in his early 30s for whom we didn't think treatment was working, and the data didn't seem to suggest treatment was working. Struggle stayed right up throughout all of treatment, that green line there. Pain stayed right up and even got worse. And then while engagement in values-based activity went up, we were worried that in a context of struggling for pain control, this was unlikely to sustain itself at 3-month follow-up. And that's what happened. Struggle stayed high, values-based activity dropped right down. And when we looked at treatment success, our outcome measures didn't seem to indicate that this was a wildly successful treatment for this individual. A lack of reliable improvement in disability, some shrinkage in that discrepancy between importance and success and values, but still probably not a successful treatment for this gentleman. As our first bit of analysis into this, we then did a case series of 21 patients who came through treatment and tracked these diary data in order to see whether or not changes in struggle, pain, and struggle, values, and pain reliably predicted reliable change in disability. And we wanted to look at, in those individuals who had that pattern of change, less struggle, more values, what was the proportion of them that actually achieved reliable change in disability? And how about the people who didn't show that pattern? What was the pattern of change? What was that relation like with regard to reliable change in disability? So 21 patients, small sample of patients. Here's what we saw in a nutshell. If there was change in struggle and values, then there was reliable change in disability at 3-month follow-up in 80% of the patients. So 8 out of 10. So our miss rate was 20, which is always important for us to keep track of in science. If there was no change in struggle and values, then 82%, I think, 9 out of 11 patients had a lack of reliable change in disability. All right? A few things I want to point out here. One is that about an 80% accuracy rate is not bad, I don't think. But also that treatment worked, got reliable change in disability in about 1 out of every 2 patients, 50%. So nobody's hitting it out of the park for sure. And whether or not we are satisfied with 1 out of every 2 patients showing reliable change in disability or not is probably a topic for a different discussion. I'd like to think we can certainly do better than this. With regard to pain intensity, this was the pattern of change for pain intensity. In those individuals who had reliable change in disability, the plus RC in the top line there, 2 of them with reliable change in disability reported decreased pain, 7 reported the same pain, 1 reported worse pain. In the individuals who had a lack of reliable change, 5 reported decreased pain, 6 reported the same pain. In essence, there was no discernible pattern here in relation to changes in pain intensity with regard to changes with reliable change in disability. We currently have under review a larger set of these analyses, and this is in 174 treated patients, and it's taken us a few years to get these data. This paper is, without a doubt, the most sophisticated set of statistical analyses I've ever done, so I'm not going to spend a ton of time doing it because it confuses me sometimes. Is something called latent growth mixture modeling. Rolls right off the tongue, but we used it to assess trajectories of change in pain and distress in patients. In other words, we wanted to know people who have more reductions in pain, do they do better in treatment? People who have more reductions in distress, do they do better in treatment? And are there discernible patterns in patients in reductions in pain and distress, or in changes in pain and distress over the course of treatment, trajectories of change? What we found across these 174 patients is that one trajectory of change for pain seemed to best characterize the entire sample, which is a quadratic decrease, which means that pain came down a little bit over the course of treatment, and that amount of change accelerated a bit towards the end. For distress, we found two distinct patterns of change. One was a quadratic decrease in distress, and the second was a strange parabolic function that was a clinical archetype we thought we saw for a long time and is similar to the first patient's data that I showed you, where people came in having a moderate amount of distress. Over the course of treatment, it looks like we made them more distressed, and then they left in about the same amount of distress as they left. And what we wanted to know was, how do these patterns of change relate to treatment outcomes at 3-month follow-up? Again, do people who have greater changes in pain have greater changes in disability, distress, pain-related medical visits? And what about these two trajectories of change for distress? People who have less distress over the course of treatment, do they have more change than these people who have this parabolic function? In a nutshell, this is what we found. Trajectory of change in pain and distress at 3-month follow-up, and we did it at post-treatment too, we looked at it, were unrelated statistically to improvements in physical disability, psychosocial disability, depression, pain-related fear, pain acceptance, values engagement, observed physical functioning, we have them do a walk task and a sit-to-stand task, and the number of pain-related medical visits. In other words, trajectory of change in these two variables, at least in the treatment that we offered, had almost nothing to do, in a predictive sense, in a statistically predictive sense, with the positive outcomes that we achieved. There are only two exceptions here. First exception was changes in pain-related anxiety were related to that pain trajectory. People who had greater reductions in pain intensity did indeed show greater reductions in pain-related anxiety. Changes in psychosocial disability were related to distress trajectory at post-treatment only, such that the people who had greater changes in distress reported greater improvements in psychosocial disability. So out of about 30 tests that I think we did, there were 2 that were significant and indicated changes, reductions in pain and distress were related. All right, we got like 5 minutes left. I'm just going to show you the treatment outcome data, and then I'm going to end in a punctual fashion. We've tried to publish our data in part so that we can see ourselves, does our treatment seem to be doing what we want it to do? This is the most recent paper we published in 2014 in the Journal of Pain. This was from that abbreviated course of rehabilitation, 2 days a week, 6.5 hours a day for 4 weeks, interdisciplinary team. And I've just converted all of the outcomes to effect sizes here for ease of presentation. I'm sure many of you out there probably know what an effect size is. For those of you who don't, effect size converts units of raw change into units of standard deviation change. So it standardizes change such that an effect size of 1, as an example, indicates that on average, the patients you've treated have shifted by 1 standard deviation between your 2 time points. Does that make sense? Did I explain that all right? Okay. By convention, an effect size that's 0.2 or above, this lower arrow bar here, is defined as a small effect size. So an effect size that's 0.2 to 0.5 is a small effect size. Colloquially, what Stanley Cohen, that good old statistician who tells us what to do in a lot of ways, what he said is that colloquially, a small effect size is a change that really only an expert eye would be able to discern. Large effect size is the upper reference bar there, 0.8 or above. My reference bar has shifted a little bit. And large effect size, an effect size of 0.8 or above, again, Cohen says colloquially, that's a change that even a non-expert eye would notice. And then right in the middle there, that middle reference bar at 0.5 is a medium effect size, 0.5 to 0.8, medium effect size. Almost invariably, effect sizes for psychological therapies are a medium effect size. That is a tried and true result, and that's true in most medical studies as well. So if you read things like Cochrane reviews or meta-analyses, they're always converting to Cohen's D. They're converting to effect size. They're converting to standard deviation. We've got our outcomes here for this particular trial, just down on the x-axis, acceptance of pain or pain willingness, the discrepancy between importance and value success, disability, that's the total score of the SIP, depression, pain-related fear, pain-related medical visits. And if you just eyeball this, you'll see that by and large, medium effect size are better. In some cases, our effects go down, like the values discrepancy goes down at 1 year follow-up. It starts as a large, and then it goes down to a medium. Some go up a little bit. Our improvements in pain-related fear go up a little bit, a greater effect size. Our reductions, not improvements in pain-related fear. That sounds like an increase, right? Our decreases in pain-related fear go up. Our decreases in pain-related medical visits go up. So we get greater decreases at 3-month follow-up. And my purpose here today is definitely not to brag about this. We've got a lot of work to do. We're getting successful treatment outcomes in 1 out of every 2 patients, and that's not good enough. But I would be happy to march these data out and put them up against any other intervention, and I think we do okay. And maybe that's important. Maybe that's good. And now we just got to try and figure out how to do better. This is one of the middle set of studies we published, and I put it up here because this is that 3-year follow-up data I'm going to show you. We published 171 patients in the first paper in Journal of Consulting and Clinical Psychology, and then we got about 65% of them to give us 3-year follow-up data. These are those 3-year data here. This is that same effect size graph, but somehow in our wisdom we thought it was wise to turn it on its side and confuse people with what we were displaying. The black bar is pre-treatment to 3-month follow-up effect size. The dashed bar is pre-treatment to 3-year follow-up effect size. And again, if you eyeball these, you see in general about a medium effect size or greater across these outcomes. Reasonable maintenance of treatment gains at 3 years, that's all right. The areas where we saw a decrement in treatment gain were pain intensity. Pain intensity was no longer statistically significant. It was no longer different at a level of statistical significance at 3-year follow-up in comparison to pre-treatment. We also saw a statistically significant reduction in physical disability, which is the third from the bottom here. And that's interesting. It's interesting to know what to make of that. In part, we can say it might not matter as much because there's reasonable maintenance of gains in other areas. In part, we might say people are 3 years older and maybe every 3 years our physical disability increases a little bit. There's a cheery thought for the day. We might say the treatment didn't do a good enough job at maintaining physical disability in here. I'm simply not sure. But at the very least, what we see is reasonable maintenance in other areas. Oh my goodness, the clock here says 42 seconds. Oh, 42 seconds over. We're not going to make it. All right, we're going to be close though. The American Psychological Association's Division of Clinical Psychology maintains a list of empirically supported treatments. What it means to be evaluated for that list is that somebody somewhere who doesn't have a dog in this race, in other words, they don't have a bias, has evaluated the data for a particular treatment and a particular condition and made a judgment. Do the data suggest that it seems to work? There are 3 primary levels of grading. There's no evidence, there's moderate evidence, or what the APA used to call a promising treatment, and then there's strong evidence, or what the APA used to call an established treatment. There's also a 4th category, which is controversial, and that's not the category you want your treatment in. So it's a little bit small here. About 6 years ago, ACT was graded as having strong research support. It's the only treatment on the Division 12 list on the Division 12 website that is for chronic pain writ large. There's evidence for CBT, and CBT is very strong, and ACT and CBT are not at war. There's evidence for CBT for specific pain conditions, low back pain, fibromyalgia, migraine pain. ACT's got evidence for everything. Or for pain, not everything, oh my goodness, I'm gonna get in trouble. ACT's got evidence for chronic pain writ large because we've never purposefully recruited by diagnosis. We assume the principles of effective functioning are the same. In order to meet that standard, essentially well-designed studies, so non-fatally flawed studies, must have been conducted by at least 2 separate research groups, so non-overlapping research groups. The findings of these studies must conform or converge to support the study's effectiveness. At the time when this grading was given, there were at least 4 groups who were doing this work. There was our group, there was Julie Wetherell's group right up the road at UCSD, and there were 2 Swedish groups, that of Ricard Wixel and Joanne Dahl. This is extended over time, and as I was saying at dinner last night, there are now studies coming out from people who I don't know, and that is that's great. That means this small, historically insular community is expanding out. So to conclude, in at least some patients, at least some of the time, pain is no longer the problem, or pain is no longer the paramount problem. And I would even go so far as to whisper in most patients, most of the time when they come to see us, pain's not the paramount problem. The problem is that, excuse me, in responding normally to pain, they've directed behavior away from areas of meaning and value and importance towards pain control, and they've been failing miserably. We have treatment methods that can directly target losses and restrictions in living. We have treatments that can work towards enhancing willingness to have pain, clarity in what's valued, and willingness to have the emotional experiences that are associated with pain. We can measure outcomes in terms of successful living, not in terms of how somebody feels. Isn't this our ultimate outcome anyway? In essence, we can augment willingness to have pain in the service of what matters. We can try and facilitate a behavioral commitment towards what matters. And this is my understanding of what we're talking about when we're talking about ACT, or acceptance and commitment therapy. A joke I made a couple of days ago that is not the joke I made up. We tend to call it ACT and not ACT. ACT sounds like ECT, which is electroconvulsive shock therapy. And that's slightly different than what we're trying to do here. Summarize with a quote that is one of my favorites from a hero of mine, Bill Fordyce. It's from a paper he wrote in The American Psychologist in '88 based on a presentation he gave at APA in '87. And this is Pain and Suffering, a Reappraisal. This is what the title of the paper is called. He says, people who have something better to do don't suffer as much. And perhaps in 7 words, or however many that is, he summarized what it's just taken me slightly longer than 45 minutes to talk about. So thanks very much for your attention. I'm happy to answer any questions that you have now, and I'm more than happy to respond to emails. So thank you.
All right. Well, he didn't cut too far into his time for us to answer a few questions. So we are taking questions here, of course. We're also going to be taking some questions from our participants online. And so our person in the back will notify me. And we've got a question right up front here, though.
Hi. I've got 2 questions, actually. The first is, living in England, did you see any difference in baseline pain between U.S. and America? The reason I wonder is I lived there, and I was shocked by how much they flogged the Tylenol. I wondered what that reflected.
Oh, they love Tylenol. The differences between people with pain in the UK and the US are almost indistinguishable in my experience. The things they go through are the same. The adequacy of socialized care versus our privatized care is maybe not as profound as we thought. The interdisciplinary pain rehab programs were not decimated there as they have been here, and maybe that's one area where they have a distinct advantage over us. Mm-hmm. And they also have socialized medicine, right? Which is perhaps a distinct advantage, access to healthcare.
And the second question. The second question is, you mentioned that their tolerance was brought up on the cold test by having them link it to the plight of a loved one. I'm wondering if making this concrete yet retrospective could be valuable for populations like I work with, like refugees with really intractable chronic pain.
Sure.
If you say, okay, in 1975, you carried someone through the jungle for 4 days eating rats, and that's why you're here, and that's why you now have grandchildren. Sure. I'm wondering if anybody's tried linking it like that, and if it's shown any effect.
It's a good question. Now, at a statistical or a research level, I'm not sure that people have. But if someone said something like that to me clinically, there's certainly some important questions there to ask, like, what was that all about? And does that stuff that was all about still matter right now in your life here as a refugee and after all the things that have gone on? And in other words, likely a conversation around that would point the direction of some values, right, that maybe that can be made use of in the here and now, therapeutically moving forward. Is that all right? Okay. Thanks for the question.
We have a question.
I have an online question, yeah. Okay. Online question from Tom from Minnesota. He wonders what the treatment included. I guess a little descriptor of what could that look like.
In 2 minutes, right? Okay. So treatment, we've done ACT in a few ways, psychology only and also interdisciplinary. My preference is interdisciplinary. I just think it works better. So it included the interdisciplinary services of a lot of people. Treatment essentially was about looking at consequences of behavior, making sure that patients' behavior was getting them the consequences they want in the longer term. That's a values-related question. Talked about, we practiced areas of where room may be made for pain. So in other words, where decision-making can happen that's somewhat independent of pain. It's a hard question to answer because there's a good big literature out there. And if Tom from Minnesota sends me an email, I'm happy to send him some of that literature. In essence, what I won't be able to explain is everything that treatment entailed, but I hope what I've done today is given you a reasonable understanding of what the purposes of treatment were, what treatment was trying to achieve, and then we can work backwards from what treatment was trying to achieve to what treatment included to try and achieve that. If that's all right, I might duck that one a little bit. Thanks.
Another question over here to the right.
Yes.
Good morning.
Morning.
If I have a compliment but also a potential technical criticism, which would you like first?
It doesn't matter. I'm flexible, man.
Okay. The technical criticism, maybe, it's a potential one. When you showed the effect sizes, I'm curious, were those within group effect sizes or between group effect sizes?
That is absolutely right. I meant to say that. So these are all uncontrolled trials.
Okay.
So these are within subject effect sizes controlled for within subject correlation. So we try and attenuate the correlation a little bit based on baseline values.
Okay, so
Absolutely.
I would be, as someone who works with effect sizes a lot, I would be using Cohen's sort of standard for those effect sizes. I think that
Right.
really applies much more accurately to between group
Yeah.
effect sizes. Otherwise, you get what looks like an inflation.
So what we did, and I can show you here, is we tried to, man, what's the formula? I say it down here. We controlled estimates for within participant correlation, and that seemed to be the best thing to do to try and get effect sizes, but I take your point as very accurate. I mean,
Yeah,
this is
and
one of the struggles.
I mean, regardless, I think you've got, those are impressive effect sizes. I just
okay.
would, I'd be a little cautious sort of thinking about
Absolutely.
them according to the same. For the compliment, so that was the technical criticism. The compliment, I'm really glad that I got here in time for your talk. I think it was very impressive to kind of connect a little bit to what Raven Sara said, and I suspect you probably know what I'm going to say, but I want to say it anyway. There's a lot of interesting connections to what you're doing and what existential psychotherapists would have been thinking about when they were developing their ideas.
Yes.
The reduction of struggle rather than emphasizing struggle is consistent with paradoxical intention.
Yep.
Connecting pain to something meaningful is classic logotherapy type
Absolutely.
of stuff, and which, unfortunately, existentialism in psychology is kind of a scientific dead end. It's hard to operationalize the things, and yet clinically it's really interesting and really valuable. Thanks.
Yeah, sure. Thank you. The way that I came to ACT was through behavior analysis, and the way that I was originally exposed to it was within the confines of an integrative psychotherapy course where we started with existential therapies. There's a lot of Gestalt in here. There is a little bit of psychoanalysis in here, at least to the extent that in ACT, we value shutting up as a therapist and listening, and I think the psychoanalysts were able to do that in spades. There's a lot of behavior analysis in here that we're trying to be sensitive to reinforcers and punishers and appetitive and aversive control and getting behavior change. And there's some CBT in here too, which is that perhaps thoughts are important but not quite as causal from an ACT perspective as CBT might say they are. So my understanding of ACT is that it is reasonably integrative of all these approaches and tries to be very clear in its outcomes, in the outcomes it's attempting to achieve. Thank you very much.
Hi, so I'm curious in any of your assessments
Thank you.
Of the outcome,
Yeah.
if there's differences that you've seen between males and females?
We have,
Or-
there was a question like this yesterday, maybe for Allison's talk. We've tried to look at treatment predictors, and we have always failed to find a salient predictor of treatment outcome. We've looked at gender, we've looked at baseline values. In general, people who are more distressed get less distressed. Is that regression to the mean or a bigger effect? But things like diagnosis and gender and age and pain duration, they don't seem to be reliable predictors of outcome, not that we can detect.
Okay, we have time for just one more way back to the right.
Hey.
Yeah, I have a question just about ACT, kind of under the bigger umbrella of CBT. You mentioned at the end almost like a comparison with CBT. My understanding is that it's, at least some consider it to be almost a evolution of other CBT type interventions. And then just if you have any take on the interplay between it and other CBT type interventions like graded exposure and activity and some of these types of things, and how, I assume it's not one or the other, that there's interplay and be done simultaneously.
I think psychology, we like to fight about theory, right? And we'll fight to the death against our fellow psychologists for that. I think we've avoided that, the CBT versus ACT wars, if you will. I think we've avoided that in pain for a few reasons. One is I think the message of ACT, which is let's get people back to living, it fits hand in glove with the reality of what pain is for a lot of folks. The two areas where I think ACT might differ from CBT are around the causality of thoughts. I think from an ACT perspective, we would say thoughts are influential, but they're not causal to behavior in the same way that cognitive therapy or people like Beck or Ellis would say they were. And I won't talk a whole lot about that, but there's a hypothesis about cognitive causality that seems to be in cognitive therapy. So ACT does not have that same causality chain. It would say that behavior is causal. The causes of behavior are multifaceted, and what we do in treatment is we try and identify the ones we think are salient, and that can include history and situation and thoughts, but it can also include a lot of other stuff. And the second difference, I think, in ACT as it compares to CBT is the centrality of values-based action as this is our outcome that we're shooting for, adequate quality of life. And I know that's in a lot of approaches, so that's not the sole ownership of ACT. And I think CBT has that in it. Goal-directed behavior is certainly a part of CBT. Some values-based action is certainly a part of it. In ACT, maybe it's a difference in focus and emphasis that, as I understand ACT, it is the focus and emphasis. You had another part, there's another part to your question that I'm not remembering at the moment.
Just the interplay between it and other types of
Okay.
CBT approaches.
Right, so I would say ACT is absolutely an exposure-based exercise, an exposure-based treatment. That's what we're trying to do. It's both exteroceptive, in other words, putting people in situations that maybe have been previously avoided, like going to the gym, but it's also interoceptive, which we know is important in exposure-based therapies too, of exposing them to internal experiences that they're trying to avoid as hard as they can. Maybe I'll stop there because I could ramble on, and I know that I got the hook coming.
Well, thank you very much.
Sure. Thank you. Thanks for having me.